So one thing I love about being here is it's just really exciting. It's very enthusiastic. A lot of kind of shift in the thought process behind how we treat patients with Parkinson's disease. I think what we're trying to move more towards is a more integrated, multidisciplinary, teamwork approach to treating patients, which I think is kind of a shift from the old-fashioned doctor-patient relationship. I think of it more now as a ship with a lot of different subspecialists that are all involved with the patient at the helm and the movement disorder neurologist as kind of the primary advisor to the captain. So I think that type of mentality is really going to optimize quality of life, being able to integrate a lot of these types of therapeutics to address the non-motor symptoms of Parkinson's disease as well as the classic motor symptoms. We're seeing a lot of new clinical treatments that are available now. We've taken some of our old medications and updated them for the future, taking mechanisms of action that we're already familiar with, that we kind of tried and true, we know they work, but they have some downsides, and now we have opportunities to use them in novel ways. So, for example, with levodopa we know is the mainstay, the gold standard of treatment for Parkinson's disease, but it's always come with its own baggage, and now we have ways to make that a little bit more user-friendly, so to speak. So we have ways to administer levodopa by inhalation. So CVT-301 is very exciting, a very novel rescue therapy that allows people to inhale the levodopa and use respiratory absorption, which is faster and has more predictable ONS. We also have subcutaneous levodopa that's in the works, as well as we're more familiar with the intrajejunal levodopa pumps. So aside from levodopa, there's several other new drugs that are in the works that I'm very excited to start using. We have a new monoamine oxidase type B inhibitor, sulfonamide, that is exciting because it has some novel mechanisms that I think can be useful. It's got some anti-glutamate activity, as well as some modulation of calcium channel blockers. May also have some anti-dyskinetic effects. Opicapone is a great new addition to our catalog of catechol-methyltransferase inhibitors, and opicapone being once daily is far more convenient and without the side effects of the agents that we're already familiar with, like diarrhea and urine discoloration. Among the dopamine agonists, we have a lot of new exciting modes of delivery. We have sublingual delivery of apomorphine, of course, the sub-Q penjet apomorphine, the subcutaneous pumps. So just a lot of new novel ways to deliver drugs that we are already familiar with that can make a patient's experience with these medications, I think, more user-friendly and with less side effects. So one of the things that I'm most excited about is bringing all of these new developments to the classroom. So my area of interest is in education. So I'm responsible for all of the clinical education programs for 3rd and 4th year students at the UC Davis School of Medicine. So I think students get very excited to learn about all of these new pharmacologic therapies, new surgical therapies, and I think what's important for me is being able to shape the new generation of Parkinson's disease specialists, because it's really certain things that we just don't learn in medical school. Being a Parkinson's disease specialist is very unique because we're not managing just one system. In Parkinson's disease, you really have to manage the total patient. their cognitive symptoms, their psychiatric symptoms, their autonomic symptoms. All of these things can arguably affect their quality of life to a much greater degree than a tremor.